and welcome to the Medi Classes postgraduate lecture series on acquired hypothyroidism. Over the last 2.5 years, we have been working on different modules related to pediatric endocrinology, and the PG lecture series has covered many like growth, calcium, electrolyte, along with thyroid and pubertal disorders. So we are going now towards acquired hypothyroidism. And acquired hypothyroidism is one condition which is quite common from a pediatric perspective and something which has significant implications in terms of short and long terms from different aspects, not just growth, but puberty, but many other issues. It can also be a cause of emergency, as was seen in this case. This was a 12-year-old boy who had presented to us with poor school performance. And at that point of time, he was found to have a low FT4 and a TSH of 9. At that point of time, the treating physician considered that this is a hypothyroidism. It's more likely to be a primary hypothyroidism because TSH is slightly high and started on thyroxine. But within a couple of weeks, the child developed hemodynamic instability and shock. And what really went wrong here was that there was an erroneous assessment in terms of thyroid function. In that, when we remember that whenever the FT4 levels are low, we expect the TSH levels to be very high. If they are not high, this suggests a central hypothyroidism. So this was a central hypothyroidism with associated multiple pituitary hormone deficiency, which was missed and resulted in this abnormalities in terms of treatment. So clearly, this is one condition which is quite common, but often can cause a lot of confusion in that perspective. So this is a rare form of acquired hypothyroidism. We'll be discussing a lot about this in that regards. All of you can go and have a look at our website learning.growsociety.in, which has got multiple sources and resources regarding pediatric endocrinology, our e-learning platform, our courses which are there, along with our fellowship and pediatric endocrinology for postgraduate courses. We run a number of activities every month, including this PG lecture series, grand rounds, and journal clubs. And we have multiple publications ranging from pediatric endocrinology protocol to basic and advanced pediatric endocrinology. And our app provides comprehensive assessment of pediatric endocrine disorders, including thyroid interpreter, which is also available. So today we're going to focus about acquired hypothyroidism. Key questions are, is it really hypothyroidism? Is it transient or permanent? What is the site, central versus peripheral? And what's the cause in that regards? So thyroid disorders, pretty much everybody who comes to us with pediatric endocrine practice requires a thyroid assessment. So anybody whom you're thinking of endocrine, think thyroid. It can cause short stature, early puberty, late puberty, cardiomyopathy. We have seen patients who presented to us with large heart because of pericardial effusion, hyponatremia, developmental delay, hyperandrogenism, fatigability. So in just the classical manifestations are there, but other manifestations can also be there, which we need to be cautious about, including emotional lability and other parameters which are there, which we can identify. Very importantly, if there is problems in the lipid profile, CPK is high, prolactin is high, there is anemia or hyponatremia also, we should always do a thyroid profile from that perspective. One condition, of course, which we have seen is the stellar mass. They present to the neurologist with headache and they found there is a large pituitary and they refer as stellar mass, but which is because of hypothyroidism. So thyroid function assessment, we already discussed that we expect that for anybody who has low thyroid, TSH should go up, T4 will go down, and T3 will be the last to go down. So in hypothyroidism, we should do both FT4 and TSH. First investigation, everybody should be FT4 and TSH. With an exception, somebody who has neurological findings, there you do T3 also to identify the MCT8 defect. So 6-year-old boy with short stature, height is 92 centimeters, weight is 16, coarse skin, TSH is normal on 3 occasions. So do you think this could still be hypothyroidism, Dr. Alappan?
Test probabilities are high in this case because the height is short.
Yeah, so TSH is normal. What was being wrong in this case?
I would like to see the T4 level. T4 level.
So here the FT4 was not done. So this is a common error. People just do TSH and then they don't identify the scenario from that regards. Remember that TSH levels does show a variation, a diurnal variation with the highest level in the morning, but this variation is not enough to allow only timely assessment. So when you say cortisol, you say 7 to 9. When you say cortisol excess, you say midnight. But in TSH, this variation is not that much. So you can do it at any point of the day. So there is 40 to 50% diurnal variation. Within an individual, it's also around 0.5, and within two different individuals, it will be 2.5. So what does it mean? It means that if my TSH was 2 consecutively and it becomes 4.5, this means that this is going up. While if another individual, the TSH was 4, it becomes 4.5, the implications are not the same. So for the same individual, you expect TSH to be within 0.5. But within other groups, you can have variation which can happen. You already discussed that TSH varies with age, so we are not talking about neonatal period. Generally, we don't treat below 10, and below 6 only. After 6 only, we start getting worried in children. The chances of reversibility of subclinical hypothyroidism in children is more as compared to adults, which has been shown, particularly if they are obese. Thyroid hormone levels, there are receptor. We need to remember that we have options of total and free hormones. Total hormones are affected by TBG, but there are robust assays. Free T4 is not affected by TBG, but there could be variability. And if you want to get really sure, you need to do an equilibrium dialysis, which is very expensive, not easily available. The heparin effect will not be there in total hormone because heparin releases free T4 from the binding site, and non-thyroid illness free T4 is not very good. So while generally FT4 is a good test in the preterm child, during pregnancy, and during the non-thyroid illness, it may not be a very reliable test in that regards. We discussed about binding globulin already, that you can have estrogen, which is going to cause increase in TBG, testosterone glucocorticoid, which will cause decrease in TBG. You can have a problem in terms of nephrotic syndrome, CLD, where the levels will be low, and these can have a significant impact. So Dr. Nimisha, a 10-year-old girl with poor concentration, she is having some short stature, but not that much. Clinically looks euthyroid. TSH is normal and T4 is low. So do you think this is central hypothyroidism?
No, sir, I would like to see pre-T4.
Because central is a quite uncommon scenario. So FT4 should be done. And in this case, FT4 was found to be normal. So this could be a TBG defect in that perspective. 17-year-old girl, Dr. Vibha, with hyperandrogenism. BMI is 28. So she is obese. And you find very bizarre report. The gynecologist has referred as thyroid hormone resistance. High T3, high T4, and TSH is normal.
So both the T3 and T4 would be high in this case because of the use of OCP pills for
Yes.
hyperandrogenism.
So we should definitely ask for the estrogen exposure. In this case, NFT4 is normal. So that gave us a clue. So be always vary about whenever you're using total hormones, whether there is any confounding state or not. So estrogen progesterone gave a picture. 11-year-old boy with liver disease, sodium is 120. So there is hyponatremia. At that point, urinary sodium was also on the lower side, and thyroid profile showed very low T3, T4 and a TSH which is normal. So again, do you think this is central?
Probably at the setting of the liver disease, the albumin levels and other binding globulins should be low, causing this low T4 and T3 levels.
So cortisol in this case was found to be also low.
So,
So this is MPHD.
slide on because
So again, this could, the CBG levels will also be low. So clearly in this case, this is because of the liver disease rather than other scenarios. So now once we know this is hypothyroidism, next question is transient. So look for obesity, drugs, which Dr. Nimisha talked about, illness becomes important from that perspective. Then how do we interpret the site of thyroid defects? So we know that if FT4 is low, TSH should be extremely high, above 20. If the FT4 is low and TSH is below 20, this is most likely to be a central one. You need to do further evaluation in that regards to rule out the cause as we discussed. So workup will depend upon the clinical scenario. So look for goiter. If the goiter is there and the goiter is hard and bossulated, that is more likely to be autoimmune thyroid disorder. Absolutely soft like a rubber ball, this will be dysharmonogenesis. Antibody status is good, but you don't need to do it in everybody. If somebody can't afford, do it only if there is subclinical, where you have a doubt of treatment. Here, TPO and TG both are recommended, but you can do TPO alone because it has got higher sensitivity and specificity. TRAB antibody should not be done. It has no role in that perspective. So as discussed, around 90 to 100% cases will be positive for TPO. 80 to 90% for thyroglobulin. Also remember that 10 to 20% normal children will also be TPO positive. And Nimisha said that if you follow them up for 5 years, only 10% will develop hypothyroidism. So many patients come to us with TPO levels. We are not very that much worried. Ultrasound is not indicated in everybody unless we are suspecting nodularity. So if you have TPO positive with asymmetrical goiter, then you can start thinking of nodularity, get an ultrasound done from that regards. Nuclear scan again only if you're suspecting a rare possibility of missed congenital hypothyroidism. Somebody with an absolutely soft goiter also has severe growth failure, has some mental subnormality. You should start thinking of a possibility in that regards. Anybody who has central hypothyroidism, FT4 which is low, and TSH which is not high, get a MRI done and anterior pituitary functions in that perspective. So how do you approach hypothyroidism? Look at FT4 levels. If the FT4 is low, look at the TSH levels. If the TSH levels are above 20, you are sure this is primary. Below 20, and some guidelines talk about 10, but I would be more cautious. I've seen patients between 10 to 20. You should look at MRI and cortisol. It may still be both central and peripheral. If the FT4 is normal and TSH is below 6, don't worry. If TSH is more than 10, most likely treatment is required. Between 6 to 10, assess risk factors like TPO positivity, goiter, family history, or a girl child. There the chances are more. There is controversy about which girls, children require treatment, but generally, if they are above 6 and TPO positive, we start treatment from that regards. Otherwise, better to follow them up over 2 to 3 months, where we'll get the idea about that. Very importantly, and this was raised by Nimisha about non-thyroidal illness, do not do a testing unless it's absolutely essential. Do FT4 and TSH. If your TSH is very, very low and FT4 is high, then it is thyrotoxicosis, very rare scenario. If your FT4 is normal, then nothing to worry, you wait and watch. If your TSH is low but not that low, so it is in the slightly detectable range, then you do a cortisol level. If cortisol is low, that could be a multiple pituitary hormone deficiency, or if the cortisol is very, very high, this will be a non-thyroidal illness. So whenever you are interpreting leopards, cortisol gives you a clue. If the cortisol is above 550, this means it's a stressed patient. That's why you have got the non-thyroidal illness. If the TSH is normal, you don't need to do anything, follow up. If it's 4.5 to 10, now this is important. You expect that with illness, TSH should be low. If TSH is high, that is very, very significant. So if your TSH is 4.5 to 10, repeat after 1 week. If it's more than 10, look at FT4. If FT4 is low, you treat. If it's normal, you can repeat from that perspective. So 12-year-old girl with obesity, Dr. Alapan, TSH is 6.2, advised treatment. Do you agree?
So this is a widely elevated TSH. Girl is already obese. So probably this is the effect.
So this is the effect and not the cause. There is no goiter, TPO is negative, no need for treatment. Dr. Nimisha, 12-year-old boy with poor school performance, FT4 is 0.6, TSH is 9, started on thyroxine, shock. What do you think was the cause? We discussed this in the beginning.
Cortisol deficiency might have possibility.
Yeah, so once he was completely fine because of low thyroid, his body was going on. You increase the energy levels, he suddenly went into crisis. So this was a cause which we need to be wary about and always rule out central hypothyroidism in that perspective. Dr. Vibha, 12-year-old boy with weakness and hyponatremia, FT4 is 1.2, TSH is 12. Cortisol is 24, ACTH is 12. So what do you think is happening here?
Cortisol is low sodium, it should be high. So
Yes.
sodium is affected, TSH is affected, so it's a case looking like a case.
So you think this is most likely a APS-like picture or a pituitary-like picture? Look at the ACTH level. So it's a pituitary problem. But why isn't TSH high?
So TSH is within the family. The central hypothyroidism, it would be
Up to 20, but FT4 is not low. So that's the main concern. Now, whether this is actually hypothyroidism or is it because of a cortisol deficiency? So what does cortisol do to TSH?
TSH.
Yeah.
So it increases the TSH level. It's not symptom like the thyroid.
So we don't need to start treatment right away, and often on follow-up, we'll find that the levels become normal. So if you have an isolated TSH elevation in somebody who has cortisol deficiency, don't treat with thyroid, wait for some time. There was partially empty sella with hydrocortisone, there was improvement, which suggested that it was the cortisol deficiency which was causing. So when you have cortisol deficiency, you have masking of DI. When you have cortisol deficiency, you have masking of hypertension, you have masking of diabetes, you have unmasking of thyroid. So this is a different perspective to think of. 13-month-old boy with developmental delay, core skin, wide anterior fontanelle, FT4 is 3, very low, TSH is 2.2. What do you think?
So presentation looks like a hypothyroidism in this case, and low FT4 level with normal TSH level probably indicates towards a
Central cause, cortisol is normal. MRI show the hypoplastic pituitary. So which defect are you looking at?
this is probably this one is normal. So O1 F1 could be one.
Power one F1 will be the most likely possibility in that regards. 6-year-old boy with meningitis, Nimisha, TSH is 0.1, FT4 is 6. Will you treat or not?
So we will repeat.
But they have to decide FT4 is low. The ICU person is asking treat or not treat. So what will tell you? This is more likely to be a non-thyroidal illness versus a central hypothyroidism. Look at the algorithm. So cortisol levels will give you a clue. Cortisol is high. So that saves you. This is because of a non-thyroidal illness. There is no need for treatment in that regards. 11-year-old boy, Dr. Vibha, with dengue fever, TSH is 12 and FT4 is 6. Again, you have a same sort of a picture. So what will you do? Will you treat or not treat?
The TSH is more than 10. So that
Yes.
TSH is more than 10 in the admitted patient, we have to start.
So this is very, very specific, very clear that when in endocrine we talked about contextual assessment, anybody who is sick should have a low TSH. High TSH means actual TSH would have been much higher than then, in which we like to go, all of you to go and have a look at our website to look at different aspects of pediatric endocrinology, look at the books, the publication, the mobile apps, and we will join again in a couple of months with the subsequent aspect.